We're going to start with some compassionate use of Lotus for TMVR. Chris?
Wonderful. All right. Thanks so much, guys, for having me here. It's been a really pleasure so far. So, here are my disclosures, and we will be using the off-label use of transcatheter valves. So this is a woman who walked into my clinic about 2.5 years ago when she first came at this time. Very, very nice woman. Honestly, she didn't look too sick from our typical standpoint, but unfortunately, she had quite a number of issues underneath the surface. So multi-vessel left main disease, severe AS, and severe mitral stenosis with heavy MAC. And the challenge was she had a portional aorta in the context of these things. Otherwise, this is a nice cabbage, double valve, and you're done. So we were faced with the dilemma of how do we try to approach this from a non-open standpoint. So first thing we decided is, well, let's get the coronaries fixed first. So it was, trifurcation stenting in the left main. This went well and was really the easiest thing to try to approach during the context of her disease. The next step, of course, was let's talk about CT planning and, let's try to figure out how we're going to conquer these valves. So as we typically do, of course, she had severe ES. We've got to get the aortic valve taken care of. And you can see here she had pretty small iliofemorals. At the time, really, there wasn't good transfemoral access. There wasn't subclavian access either. And at the time, really before transcable, we felt the most appropriate approach would be transapical. Now, we thought on that, well, maybe we should be fixing both valves at the same time. She had heavy MAC. She knows she has pretty significant mitral stenosis, so the question was, could we fix both valves at the same time? The challenge was, do we do this with a reasonable risk or not? So as Myra, who really is the guru, and I should defer all these things really to her up here, we looked at this and we said, this is a patient who has a very high risk of LVOT obstruction. So if you take a look at this, she got an aortomitral angle of 106 degrees and a very thick septal bulge. So at the time, we really felt it was prohibitive of a risk to try to actually treat her from a transcatheter standpoint for a mitral valve. Now, the other thing we looked at was in predicted Neo-LVOT. And when you look at this, and I have to give complete credit to Dee Dee Wang, who is absolutely phenomenal with this stuff, there was a predicted Neo-LVOT of only 42 millimeters. So we had zero doubt that if by doing a transcatheter therapy in this patient, we were going to leave her with a significant outflow tract gradient that really would not be acceptable and potentially not compatible with life. And again, just for a little refresher, the reason that this would have been an issue is because in these patients with their native valves, we simulate fixed SAM because of the anterior mitral leaflet coming across that valve, really causing it to almost be like a covered stent, obstructing the flow out of the LVOT. So we moved forward, did a nice simple transapical TAVR. That was fine and dandy. Everything was nice at the beginning, but she comes back to 6 months follow-up, and she's telling me, man, I'm really short of breath. Maybe even worse than she felt before. No AI on echo. And when we take a look at her mitral valve, clearly, not even with any gradients, look at this, clearly this thing is not really opening and closing. Reassess, here we have it resting with a reasonable heart rate, a mean gradient already of 15. So again, we're stuck in the situation. How do we begin to try to treat this? And you can appreciate here, there's plenty of MAC there, potential landing zone, but we're stuck. We're really stuck with the other issues. Now again, I mentioned to you earlier, we have several risk factors for this LVOT issue that's a problem. Again, the septal bulge, and the other one being the angle, that aortomitral angle. So what do? She's very high risk for LVOT obstruction. We don't have a good surgical bailout. We really want to have in this patient a confidence that in our results we'll have the ability to remove it if needed, because again, we can't leave her with such a catastrophic option. So our option or our decision in that day is that we were going to do an ethanol septal ablation, and then we're going to actually request for compassionate use of Lotus and MAC from the FDA so that if we were in trouble, even after that we'd have the ability to actually take the valve out afterwards so that we have done essentially no harm. So here you can appreciate the ethanol septal ablation. We had a very nice reduction. We then repeated the CT 6 weeks later, and surprisingly, we saved a very significant improvement here now, going from a Neo-LVOT predicted from 42 millimeters to 280 millimeters. That's really much more in the acceptable potential range of LVOT obstruction. But we'd already gone down the path, and we still felt that using the Lotus valve, in case we had issues, is the most appropriate at this time. So we went from a transapical approach, and you can see us putting the safari wire into the left atrium here. We're then getting the valve lined up in a coplanar view with the MAC. And we're really heavily relying on TE guidance for landing this valve. And if you remember, the Lotus valve and why it provides a challenge with this landing is because it's foreshortening selectively on the distal end of it. So we've got to kind of predict how far it's actually going to foreshorten, because we only want to leave 1 or 2 millimeters actually in the atrium because it has such a big skirt around there. And the concern was if we're too deep in the atrium, that skirt over time could actually have wear and tear and actually cause further issues. So we were happy with this deployment distance. We ended up very happy when we actually got to the thing about 1 millimeter into the left atrium. We were tugging on it, confident of the secureness of this valve. Then we, again, confirmed all these things on echo, and again, we're very happy with the location. Most importantly here, we then go look, do we have a good gradient? There was no gradient afterwards with the dual lumen, so we were happy that we would be doing no harm by deploying this valve. We deploy the valve, and we see there's no leak, there's no significant gradient. And you can appreciate again here, very nice image, no leak, all the blood is moving finally in the right direction. This patient did remarkable afterwards. She was extubated on the table. Within 6 hours, this lady felt like a new person. She was actually literally walking around the laps of the ICU telling us that. She actually would not let me wheel her in a stretcher up to the next floor when she went up the next day. She actually walked to the elevator and up to the next room, went home post-op day 2. Within 1 week, she was walking 2.5 miles, felt like a new person. Here's her 30-day follow-up CT. Again, results looked really good. The results have been consistent all the way out to a year now. She continues to feel well and sends me cards on the anniversaries. And I think it's a nice example of how we can potentially have different approaches to try to deal with LVOT issues. I want to give credit to Dee Dee, who's done an amazing job doing all this imaging. Myra will be up later, and she can share her email if she'd like, but I think that Myra deserves so much credit in this space, and she's really guided so many of us in how to get through these tough situations. So that's what I got.
Chris, obviously one of the key elements that you touched on briefly is the removability, retrievability piece, and why you got a specific valve. Just comment on that a little bit as we look at the U.S. landscape of what's happening.
Yeah, I think the challenge, especially at that time, now this is a while ago, this case, about 1.5 years, I think ago, almost 2 years ago actually we did it. And because of that, we didn't know nearly the amount of information from a planning standpoint that Myra has really guided us on. And so I think at this point, I maybe wouldn't have needed to use, as you probably agree, a repositional valve. We probably could have gone transeptal when we knew we had Neo-LVOT of 270 or 280. But at that time, we didn't have as much information. We weren't as confident in those things. And again, I think the transeptal route is really the nicest thing. So if you had to go transapical, I think it adds a nice benefit. And maybe if you really, really are not sure that having this technology to use in this situation is great. But otherwise, I think transeptal is just so smooth in these procedures now.
Chris, when you did your CT, did you go back and compare what the actual Neo-LVOT was after the implant with the predicted Neo-LVOT?
That's a good question. I actually don't think that we did that. That would be actually that would be an interest. We need to do that. Have we done that in any of the study yet, Myra?
That's what we're doing in the Mitral trial.
Yeah.
So we've done it.
There is
Roughly.
there is data that Philippe and Jonathan Leipzig they have done on validating the Neo-LVOT type concept. John Lesser, you want to comment on that at all?
Agreed.
So it's pretty predictive.
Yeah, I think the Intrepid ones are a little overestimated at time or underestimated the Neo-LVOT we've been
probably
finding.
more predictive in the dedicated TMVR devices. For the Edwards and other ones in which you may have relative degrees of atrialization, it may be a little bit different, but for the 10-9-12 and such, I think it's pretty accurate.
Oh, that's a good point too. Yeah, because
what there is.
Can I ask John, when you do this, Johnny, so you're typically doing this in end systole, see what the smallest Neo-LVOT is, but blood flow is usually at the beginning of systole. Are you starting to average this Neo-LVOT over time as it changes?
John?
What we do is wait until the very last part of the cycle where the valve is fully open.
Yeah.
And then the heart gets smaller, but the valve is closed. So we just use that one particular.
Which is when the blood flow is actually down
That's
some of
right.
the slowest.
It may be, but the valve is still open.
Yeah, that's what
But you're also bracketing what's the size of the ventricle.
And Chris, I think you showed perhaps the animation piece of the obstruction of superimposing the valve in it. Did you use any CT modeling and actually make the pictures of the valve in the CT modeling? Anybody do that for this case?
Print it out?
No, not 3D, not the 3D printer yet, but just overlay the images on CT to see where it was.
Oh yeah. So that's exactly what we did. Yeah, on those ones models. So the model will, put essentially the valve of choice in there. You can adjust the height, new predictions. Absolutely.
Yeah, and Didi has done also the tilting. So if
Right.
you tilt it back one way or another, you can also impact the size of the Neo-LVOT, although it's a little bit naive to predict that we can do that.
Yeah.
Do a conceptual approach, but if you have a concept, maybe choosing your axis, could also play a role.
Jeff Palma just mentioned that this morning in this session, of using our CTs better for the image overlay as well as moving to 3D printing. Whether you or John want to comment on moving in this direction just for 3D printing and what we're doing with the modeling.
Well, we thought 3D printing would be the answer, and we started doing that at the very beginning, like 3 or 4 years ago. The problem with that is that the plastic, is a different level, so we have this discussion that we do need to have. It's not just having the 3D print, but it's trying to predict the tensile force of the tissue that you're working with.
Right.
What is that you have calcium, you have liquid tissue and all that, and that was very hard back then. I don't know what we are now, but it was very hard back then to predict. And it's also very expensive tool, so we did it several times, and then that's when we started doing the CAD and computer-aided design and started to work with
Right.
3D imaging of the CT manually, and then there were software that became available, like Dimensions and
Right.
It was an evolution from not knowing anything to 3D printing to manual CAD modeling to commercially available software that allow you to do that. And I think now we're at the stage where you can, with full level of confidence, make sure you predict the Neo-LVOT, go back to your post-CT and measure the actual Neo-LVOT, and you see that it's very, very easy.
John, go ahead.
Yeah, the one variable is the anterior mitral leaflet, and that's why you need to at least have some extra room if you can.
Right.
And we've had some issues with that.
Yeah, we had a case of valve impingement today, and we talked about the fact that both 3D printing and even this imaging with CAT doesn't really have the tissue piece and the mobility part of it and what can be tricky about it.
We need to be able to print compliance.
Right, exactly. So we probably have time for one more comment or question. Okay.
So one of the issues that Neo-LVOT is we're always measuring area. The area doesn't usually correspond with the velocity of blood flow. And the Doppler usually tells you how many times we have seen what looks like a narrow LVOT. But the peak Doppler velocity is only about 1.7 meters per second. That doesn't translate into any significant gradient. That's very important to remember. The physiology is what gives you the symptoms, not the area. So the area might change dynamically without a change in physiology. That ain't going to affect anything. The second thing is some of these patients have an open Neo-LVOT, which looks like substantial. You put them on a bike exercise, they generate an LVOT gradient.
Mm-hmm.
So an exercise-induced gradient is something unexplored in these patients, and that we have to remember too. Ultimately, it's the physiology that drives the symptoms.
John, last word maybe. Myra's got one.
The area was derived by a study in hypertrophic cardiomyopathy. And so it's a three-dimensional object under stress, and that's the best that was done.
Right.
No one really knows, and you're right, it could be it could be 1.5 would be okay, it could be a little over 2 is okay.
Right. Because we've
Okay.
seen narrow LVOT areas, but not the velocity.
All right. I lied. Myra, last word.
We're looking at Neo-LVOT area, but lately, in the last 2 or 3 months, I've been thinking that we need to look at Neo-LVOT area index to correct for body size. Because we have had patients who are 145 centimeters tall, and we have treated them with smaller Neo-LVOTs. But when we factor the Neo-LVOT area index, then they do well, and it can be the opposite for a very tall person, and I do not know the cutoffs for that. We barely know now the cutoff